in the next 2 weeks there's going to be a hormone that will be released. Obanga obadde wakamaliriza ovulation yo, okay, mu weeks ebbiri ezigenda okuddako wagenda kubeerawo hormone egenda okubanga efuluma. Hormone eno gye bayise progesterone hormone, and then waliwo ne hormone gye bayise estrogen. Hormone eno nayo epulira paati nnene nnyo okulaba nti cycle y'omukyala etambula bulungi. Estrogen hormone eyambako n'okulaba nti amagumba ag'omukyala gaba at least of normal density, eyambako ne periods ez'omukyala okubanga zitambula bulungi. And then waliwo ne hormone bagiyita luteinizing hormone. Luteinizing hormone specifically yeno hormone eleeta ovulation okubanga etekinga place bulungi. Luteinizing hormone yeno hormone ediringa ne ovulation nebanga etekinga place bulungi, ovulation nebanga etambula bulungi. Omukyala eyeebuuza nti naye ngate yeeta ovulatinga, ebiseera ebisinga yandibanga alinamuko ku changes ne hormone gye bayise luteinizing hormone. So oyinza okwebuuza naye ate progesterone hormone ye kyeki, hormone kyeyo gye bayita progesterone. Progesterone hormone yeno hormone efuluma mu weeks ezebbiri eziddirira ng'omukyala amaliriza oku-ovulatinga. So specifically kyekola ebe eyambako okulaba nti supporting olubuto ne luba nga lweyongera okubanga lukula paka ku myezi 9. Progesterone hormone is a hormone that is actually released in the second cycle, in the second 2 weeks, immediately after your ovulation. So when you take a closer look at the woman's uterus, there is this part known as the cervix or the cervical part of your uterus, and then we have the private parts, and then we do have that inner lining which is also known as the endometrium. Kana akawubyako omunda kebayitaka endometrium. Era ebiseera ebisinga akawubi kana ak'omunda kekwatako omwana n'akula. The endometrium is where implantation takes place. It is that part of your uterus where the baby attaches and then grows up to 9 months. Endometrium eno ebeera regulated oba ebeera controlled ne hormones bbiri. Waliwo hormone esooka gye bayise estrogen hormone, and then waliwo hormone eyokubiri gye bayise progesterone hormone. Hormones zino ebbiri zino okubanga zibalansinga omukyala okubanga alaba periods ze bulungi. Estrogen hormone ne progesterone hormone we ziba tezibalansinga, ebiseera ebisinga periods ez'omukyala ziyinza okubanga ate tezitambula bulungi. So obanga obadde gwe weebuuza naye ate ku lwaki periods zo tezitambula bulungi, kiyinza okubanga maybe kiva ku hormones zino ebbiri. Hormone esooka gye bayise estrogen ne hormone eyokubiri gye bayise progesterone zirina okubanga zibalansinga obulungi. So bw'obanga oli kwebuuza naye progesterone hormone kyeki? Ekirungo kino oba hormone eno gye bayise progesterone yeno hormone eyiika mu mubiri gw'omukyala wabanga abadde amaliriza ovulation. Hormone eno eyambako kulaba nga esupportinga omwana ono ali okukula munda mu n'abaana n'abanga asobola okugenda paka ku myezi 9. Okay? Hormone eno webanga ebadde emala bulungi olubuto lujagenda paka ku myezi 9. Naye hormone eno gye bayise progesterone weba temala bulungi olubuto ebiseera ebisinga luyinza obutasobola kugenda paka ku myezi 9, kisobola okuviirako omukyala okufuna kye tuyise miscarriages. So omukyala wabanga alina low progesterone hormone wayinza okubeerawo challenge nti olubuto lusobola okubanga terugenda paka ku myezi 9. When a woman has low progesterone hormone, normally there's a risk that the pregnancy might actually not go up to 9 months. And remember, estrogen hormone nayo nnungi nnyo. Jjukira ngambye nti estrogen eno erina okubanga ebalansinga ne progesterone omukyala okubanga asobola okusitula olubuto okubanga lugenda paka ku myezi 9. Hormone endala gye njagala okwogerako yeno gye bayise luteinizing hormone. Hormone eno tugiyite luteinizing hormone kyekola eyambako ennyo okulaba nti omukyala ono agenda bulungi mu ovulation. So luteinizing hormone eyambako ennyo okulaba nti omukyalo ono agenda bulungi mu ovulation ava okutweyungako kati tapping ku screen mikono gyaffe nabo balabe nga ate bajja ku musomo gwaffe guno ogwaleero bampita Gerald Massa omusawo Gerald Massa the fertility coach obanga obadde olina ebibuuzo ebikwatagana ne hormones osobola okuba nga obiteekayo nja kuba nkuddamu ebibuuzo byonna so ngambye nti progesterone hormone eyambako okulaba nti omwana waba yeekutte ku kisenge kino ajja kuba asigalako okumala emyezi 9 months. Nengamba nti estrogen hormone eno yo webanga ebadde ate emala bulungi periods ez'omukyala zijja kuba zifuluma bulungi oba zijja kuba zitambula bulungi. Nengamba nti luteinizing hormone webanga ebadde emala bulungi omukyala ono ajja kuba agenda bulungi mu ovulation ajja kuba ovulatinga obulungi. Kanziremu progesterone hormone eyambako okulaba nti omwana aba yeekutte ku kisenge kino eky'anabaana agenda paka mu myezi 9. Estrogen hormone eyambako okulaba nti omukyala ono periods ze zitambula bulungi and then luteinizing hormone eyambako okulaba nti omukyala ovulatinga obulungi. At this point oyinza okwebuuza n'ogamba nti naye ate zino hormones ng'ogyeko ekyo zikola ki ekirala. Estrogen hormone eno ne progesterone hormone eno zino ebbiri zino baziyita the steroid hormones. So estrogen ne progesterone zezo hormones eziyambako mu basajja okulaba nti omusajja abeera ne hormone ey'ekisajja gye bayise testosterone ng'emala bulungi. Omusajja wabanga abadde alinamuuko ku buzibu ne hormone gye bayise testosterone ebiseera ebisinga oyinza okusanga nga ate ne progesterone hormone ye oba estrogen hormone ye nazo tezimala obulungi. Kino kisobola okuba nga kiviirako omusajja okuba nga akendeera amaanyi ag'ekisajja. Omusajja ayinza okufuna challenges okufunisa mukyala we olubuto. Leero tuli kwogera ku hormones gwe abadde yeebuuza nti naye ate hormones okoze test oli kwebuuza hormones kitegeeza ki. Hormones are chemical messengers. In this video today, in this live session, it's a live session, I'm talking about fertility hormones. I'm called Gerald Massa and I'm a fertility coach. I was saying that we have a hormone known as progesterone hormone. Progesterone hormone is a hormone that is actually released in the second phase of your menstrual cycle. It's actually released by that egg that was supposed to be fertilized, known as the corpus luteum. And then after pregnancy has taken place, after implantation has taken place onto the inside of your wall, let's say when that fertilized egg has attached itself inside here, and then implantation has taken place, the inside here where the placenta is going to be attached, it's actually going to continue releasing progesterone hormone. So progesterone hormone is released by the placenta after pregnancy has happened, and then its main function is to actually support the pregnancy so that the pregnancy can go up to term. And then estrogen hormone specifically is responsible for regulating a woman's periods so that her periods can be very normal, so that her periods can be consistent. Remember, luteinizing hormone is a hormone that is very, very much needed in ovulation. If a woman is having difficulties undergoing ovulation or ovulating, then she could actually be having issues with her LH or luteinizing hormone. And remember, hormones are very, very important. There are several hormones that actually play a very big part in the journey of the fertility of a woman. So if you actually have questions about hormones, you can ask your questions. I'll be able to reply. Obanga obadde olina ebibuuzo byonna ku hormones, osobola okubanga obiteekayo wansi mu comments, nja kuba nkuddamu. And then of course jjukira leero ndikwogera ku progesterone hormone, ndikwogera ku estrogen hormone, ndikwogera ku luteinizing hormone. Nengamba nti zino hormones zino za nkizo nnyo mu mukyala. Ne mu basajja nabo of course hormone eno naffe tugyetaaga ng'omusajja obuba weetaaga hormones zino okubanga zibalansinga. Jjukira mu musajja hormone eno gye bayise luteinizing hormone nungi nnyo, yankizo nnyo mu musajja kuba waba otunuulidde system ey'omusajja, hormone eno gye bayise LH mu musajja kyekola weba genze mu nsigo ez'omusajja, katugeze zino nsigo ez'omusajja, munda muno mulimu obutoffaali obukola enkwaso. Obutoffaali buno bwa mirundi ebiri. Waliwo type ey'akatoffaali gye bayise the Sertoli cells, and then of course waliwo ne ke bayise the Leydig cells. Buno obutoffaali obubiri buno weba bufunye hormone eno LH okuva mu bwongo, Hormone eno wetuuka mu butofaali buno obw'ensigo ez'omusajja egenda kuba oba bugenda kuba bufulumya enkwaso ezimala obulungi. Kitegeeza nti omusajja wabanga abadde alina obuzibu ne hormone eno gye bayise LH hormone, ebiseera ebisinga oyinza okusanga ng'ate aba n'enkwaso entono ennyo. What I was saying is that in a man, there's this hormone known as LH hormone, luteinizing hormone. This hormone is actually released from the brain, okay? And then it travels to the man's testes, okay? When it reaches the man's testes, it actually initiates a process. It actually leads to the production of sufficient sperms. So if a man has low sperm counts, if a man is failing to make his woman pregnant, then it could actually be an issue with a hormone known as luteinizing hormone, because a man could actually do a sperm analysis test, and then the test is actually very maybe the test is showing changes, but still if this man does not do the LH hormonal test, he may actually not find the main reason. He may actually fail to find the main reason as to why he's not able to make his woman pregnant. So let me go through the questions. Kampite mu bibuuzo mikwano gyaffe abatweyunzeeko mbaniriza Seera nkwaniriza ku mukutu gwaffe guno musawo Gerald Massa Fertility live show. Webalira ddala okutweyungako. Amoti, thanks for joining. Caroline, thanks for joining. Caroline, yes, Caroline, you have a question. Okay, good evening, Caroline. How are you doing today? Hope everyone is okay. Yes, so Mrs. K, she said that talk about PCOS. Yes, I'm going to talk about PCOS, polycystic ovarian syndrome. And then the next question, I got my periods on 25th of September and I finished it on 30th. Okay, so let me begin on the questions immediately. Okay, then keep tapping on the screen so that many of our friends can join us. Yes, tapping on screen so that mikono gyaffe bajje ku live session eno twongere okuba nga tumanya ku journey eya fertility, twongere okuba nga tumanya ku issues eza fertility. Tapping on screen mukwano gwange eyakeyunga ku live session eno. So PCOS. The question is coming in from Mrs. K. Mukwano gwaffe Mrs. K abuuziza ekibuuzo n'agamba nti njogere ku PCOS. Okay, so PCOS specifically, P stands for poly, C stands for cystic, and then O stands for ovarian, and then S stands for syndrome. Polycystic ovarian syndrome. Mukwano gwaffe agambye nti njogere ku PCOS n'engamba nti PCOS, P stands for polycystic ovarian syndrome. PCOS specifically means that there's something that is happening to the woman's ovaries. PCOS kitegeeza nti waliwo ekituuse ku ovaries ez'omukyala oba waliwo ekituuse ku magi ag'omukyala. Oyinza okwebuuza nti naye kaakati musawo Gerald oli kwogera ku PCOS then oli kwogera ne ku magi, exactly ki kyennyini ky'oba otegeeza? Let's take a closer look at the woman's reproductive system. Of course, we have the private parts and then we have the inner lining, where the baby implants, where the baby attaches themselves. Okay, we have the tubes. Okay, and then we have this part of the tube known as the fimbrial part of the fallopian tube. We have the big ovarian tissue, and then we have this side also the big ovarian tissue. We do also have the follicles in here growing. Okay, follicles growing or the eggs growing. Mukwano gwaffe agambye nti njogere ku PCOS era ndi ku PCOS kati gwe ndi okwogerako n'engamba nti PCOS kitegeeza nti ekisawo kino eky'amagi mu kifo ky'okubeeramu eggi erimu eddene erigenda okuba nga lifuuka omwana, lino eggi eddene liri replaced n'obugi obutono. PCOS simply means that instead of the ovarian tissue being with such an appearance, okay, with a big egg that is supposed to be fertilized and then the smaller eggs known as the smaller follicles. In PCOS, normally the ovarian tissue of a woman or the ovary where the eggs are growing from is normally lined with small follicles. Mu kirwadde kya PCOS, omukyala eyandibadde nga abeera n'ekisawo ekirimu amagi wegati nga mulimu eggi eddene n'akagi n'obugi obutono, mu PCOS kiba kitegeeza nti omukyala ono abeera n'ekisawo nga kinene naye obugi bubeeramu nga butono nnyo. When your doctor does the counting of these small follicles, normally your doctor will tell you that there are 10 or even more small follicles. Okola scan doctor n'agamba nti olina PCOS, ebiseera ebisinga ojja kusanga ng'ekisawo kinene naye nga mulimu obujinga bungi nnyo obutono nnyo ng'ate tebusobola kuba ng'ate bufuuka omwana. So oyinza okwebuuza n'ogamba nti naye kaakati kino kyonna musawo kyogeddeko PCOS, omukyala amanya atya nti alina PCOS? How can a woman know that she has PCOS? Number one, the signs of PCOS. Signs eza PCOS. Omukyala amanya atya nti alina PCOS? My friends, keep tapping on the screen, and then of course let me know if you are able to hear my voice. Let me know. Yes, I could be talking when I'm talking to myself and no one is hearing. I'll be tapping on screen mmanye nti muli kuwulira bye ndi okwogera. Yes, nyinza okwogera nga nzaali okweyogerera nze kanga like nga temuli kuwulira kye njogera. Yes, keep tapping on the screen so that I can know, and then of course you can also comment where you are watching from. Yes, you can comment where you are watching from, whether you are in Uganda, Kenya, South Africa, UK. You can actually comment in the comments so that I can know where my friends are watching from. Yes, tapping up screen, and then osobola okuntegezaako wa woli okulabira live eno. Then of course tuyongera okubanga ate twongera okusoma ku issues eza fertility. Okay, I can see. Keep tapping on the screen. So what I was saying is that when you take a closer look, an ovarian tissue with PCOS, it appears like this. Okay, there are small eggs on the sides. Okay, these small eggs are actually known as follicles. Normally they are so small in such a way that they are around 1 centimeter. They are so small, but ideally in a normal ovarian tissue, there should be a dominant egg. And this dominant egg is always released around your time of ovulation. Mumukyala alina amagige nga gali normal, okay? Ekisawo kye kibeeramu eggi eddene erigenda okufuuka omwana lye tuyise the dominant egg. And then kubeerako obujjo obutono eno ku mabbali, okay? Buno bwe tuyita bu egg reserves. Buba bulinda nti singa lino terifuuka mwana, then buno bwe bujja okuba nga ate bukola ki? Budda ku line ey'okuba nga ate nabo bubeera ready. So PCOS, basically the signs of PCOS, that's what I'm talking about. The first sign of PCOS is actually what we call irregular periods. So a woman who is actually having irregular periods, this does not confirm that you have PCOS, but it could actually be one of the signs pointing towards PCOS. Omukyala ayinza okwebuuza nti naye ate amanya atya nti yandibanga alina ekirwadde ekya PCOS? Nengamba nti sayini esooka omukyala gy'asobola okulabirako nti yandibanga alina PCOS kwe kuba nti abeera n'ekyetuyise irregular periods. Wemba njogedde ku irregular periods, oyinza okwebuuza n'ogamba nti naye kaakati musawo Gerald oyogedde ku irregular periods. Irregular periods like kiba kitegeeza ki? Irregular periods kiba kitegeeza nti periods wazirabye leero nga meka? Leero nga 11, okay, omwezi ogw'ekkumi 2025. And then omwezi oguddako obadde osuubira okulaba periods zo era nga 11 omwezi ogw'ekkumi n'ogumu November 2025. Then omwezi oguddako osuubira okulaba nga 11 omwezi ogwa December 2025. Waba nga wabaddewo enkyukakyuka eba ya lunaku lumu, instead of 11 ne wayitawo lunaku lumu n'ogiraba nga 12, oba eba ya lunaku lumu nga 11 terunatuuka. Irregular periods kiba kitegeeza nti instead of okuziraba mu luno olunaku oyisaawo weeks nga 3 oba n'omwezi omulamba oba n'omissinga guno omwezi n'olaba guno omwezi. Ekyo kye bayita irregular periods. I was talking about irregular periods, and many times a lady can actually say, but what do you mean by irregular periods? Irregular periods simply means that you are supposed to see your periods. Today is 11th, okay, because today we are live on 11th of October. So if you have seen your periods on 11th, you are supposed to see your periods next month on 11th. And then you're supposed to see your periods again the next month on 11th. If there are to be any changes, the changes can actually be by 1 day. Instead of 11th, you could actually see them on 12th. That is within the normal, okay? A difference of 1 day, more than 1 day or less than 1 day, maybe you see them on 9th, that is very okay. But if you actually see your periods today, and then next month, you see your periods maybe around 20th instead of 11th, or you even miss this month and then you see your periods here, and this goes on for some time, then this could actually be the first confirmation that you are having irregular periods. But it does not confirm that you have PCOS, okay? But the first sign of PCOS is irregular periods, and this is what I was explaining But then kwogera ku irregular periods. I hope if you have been having questions about irregular periods, now you have the answer. Next sign of PCOS, okay? I'm talking about PCOS. Ndikwogera ku signs eza PCOS. Nengamba nti sign esooka ya irregular periods. Nengamba nti irregular periods kiba kitegeeza nti periods ozirabye leero nga 11 olina okuddamu n'oziraba omwezi oguddako nga 11 n'omwezi oguddako nga 11 bw'otyo. Wabeerawo enkyukakyuka eba ya lunaku lumu, okay? Eba ya lunaku lumu n'oba nti instead of 11 ozirabye nga 12. Mu PCOS kiba kitegeeza nti periods aziraba guno omwezi, omukyala alina PCOS aziraba guno omwezi, and then omwezi oguddako n'amiisinga, then omwezi oguddako n'alaba periods ze, then omwezi oguddako n'amiisinga, oba n'akubawo endobo ey'emyezi 6 nga talaba periods ze. Mukwano obanga obadde ofuna ekintu ekyefaananyiriza bwe kityo kyandibanga bye bimu ebiri okulaga nti maybe wandibanga otandise okufuna signs eza PCOS. Tekikonfaminga, jjukira okukonfaminga nti olina PCOS, olina ogenda mu ddwaliro, then dokita wo ye kennyini n'akonfaminga, n'akola tests ezikonfaminga nti olina PCOS, okay? Totula waka n'olaba periods ezi omisinzemu omwezi ogumu n'ogamba nti olina PCOS. Nedda. PCOS has to be confirmed in a hospital near you. Next sign of PCOS is actually there's going to be what we call hyperandrogenesis, okay? Hyperandrogens. Basically, there's going to be an increase in the male hormones, okay? The male hormones are the ones known as androgens. Keep tapping on the screen. Keep tapping on the screen, my friends. Tapping on screen. Live here for yongero kubanga etambula. So the male hormones are the ones known as the androgens. A woman who is developing PCOS, in most cases, in her blood, these hormones known as androgens are going to increase. They are going to increase in their amount. How can you confirm that these hormones have increased? When you go to a hospital, your doctor will most likely do a test of these hormones, okay? These androgens. These hormones here are androgens, and the commonest test is actually the test for testosterone. Testosterone is a male hormone. Girls are born with testosterone, but it's supposed to be low, okay? Something around 0 to maybe 0 up to maybe around 1 point something. But if a girl wakes up one day, she goes to hospital, and then the test results are showing that her testosterone is 5, her testosterone is 10, her testosterone is 20, then it could actually raise a red flag. It could actually be one of the early signs of PCOS, okay? So a woman who is having PCOS, normally there's going to be what we call hyperandrogenesis. Male hormones tend to increase. How can you confirm that the male hormones have increased? Your doctor will do what we call a testosterone hormonal test. It could be either the free testosterone or the total testosterone. This decision will be made by your doctor. A woman who is having PCOS, normally there's going to be an increase in a hormone known as DHEA. DHEA, dehydroepiandrosterone, dehydroepiandrosterone. And by the way, talking about DHEA, there are lots of our friends who actually like taking supplements, and my humble advice is that please always, before you take any supplement, before you take any medication, it's always advisable that you actually confirm what you're going to take with your doctor, because you could take a supplement and yet you already have PCOS, and then you take a supplement which is actually containing DHEA, okay, and then you could think that you're managing PCOS, and yet you're making things worse. You are increasing the androgens. So don't take supplements without actually confirming with your doctor. Self-medication is not good. But then kwogera ku sign eyokubiri eya PCOS, nengamba nti, okay, yeah, keep tapping on the screen. So nengamba nti sign eyokubiri eya PCOS yeno gye tuyise hyperandrogenesis. Hyperandrogenesis kiba kitegeeza nti hormones ez'abasajja tuziyite the androgens zeeyongera okulinnya mu mwana omuwala atandise okufuna PCOS. Jjukira PCOS terinda bakyala bafumbo booka n'eryoka ejja, nedda. Mulimu abaana abawala abali mu myaka bakyasoma, okay, bali mu secondary school naye nga ate balina PCOS. Tebagendangako mu ddwaliro, nakindi maybe tebakizuulanga oba tebabatwalangako mu ddwaliro okukonfaminga oba bandibanga bali ku risk eya PCOS. Naye omwana yenna alina omuwala yamala dda okugenda mu periods, yatandika dda okugenda mu periods, naye ate atandise okubanga periods zitandika okubeera irregular, atandise okubanga afuna signs eza hyperandrogenesis, hormones ez'abasajja ezeyongedde okubanga nyingi, omwana omuwala atandise okufuna ebirevu nga bingi nnyo, omubiri gwe gujjuddeko enviiri, eddoboozi litandise okukyuka, and then of course atandise okugejja, atandise okuteekako weight, ate weight eno nga wano ku lubuto, essava ery'oku lubuto nga lyeyongedde okubanga lyeyongedde okubanga lingi nnyo, agezaako okuluzinga weight, akola dduyiro, asiiba, naye ng'era akyateekako weight, kyandibanga maybe atandise okubanga afuna signs oba obubonero obwa PCOS. Tekikonfaminga nti alina PCOS, naye waba agenze mu ddwaliro basobola okukola tests ezikonfaminga nti yandibanga alina PCOS. So I was talking about the signs of PCOS. The first one is irregular periods. The next sign is hyperandrogenesis. Okay, the male hormones will actually increase. Still talking about PCOS signs. The first one was actually irregular periods, and then the next one is actually hyperandrogenesis, or the androgens, the male hormones will actually increase. And then the next sign of PCOS is actually what we call insulin resistance. Insulin resistance. Ndikogera ku signs eza PCOS, nengamba nti sign eyokusatu eya PCOS yeno gye tuyise insulin resistance. Sign ene esooka ya irregular periods ngimaliriza, androgens ngimaliriza, hormones ez'abasajja nga nyingi. So sign eyokubiri eya PCOS yeno gye tuyise insulin resistance. The third sign of PCOS is insulin resistance. You could be asking yourself, what do you mean by insulin resistance? Okay, Gerald Massa, the fertility coach, you are talking about insulin resistance as a sign of PCOS. What do you mean by insulin resistance? Very simple. So when you have a meal, let's say you eat rice, maybe you eat some posho, or even you eat some chapati, what is going to actually be the end product is glucose. In whatever carbohydrates you've eaten, there's going to be glucose being our end product in the of course in the liver and in your body. So glucose specifically, when it is in your blood, okay, bloodstream. Now this is in normal circumstances. The glucose is actually increasing in your bloodstream. As the glucose levels are rising in your body as a woman, as the glucose levels are increasing as a result of what you ate, the brain is going to sense, okay? The brain is going to sense that, you know what, the glucose levels are increasing. When the brain senses that the glucose levels have increased, the brain will actually send signals to your pancreas. The pancreas specifically releases a hormone known as insulin. When insulin has been released as a result of your brain sending these messages to the pancreas, insulin will travel into your bloodstream, and then insulin will convert glucose into something known as glycogen. Glycogen is basically the store, or it's a form in which the excess glucose is stored. These are stores of excess glucose. When this particular person goes into fasting, okay, maybe she ate today but tomorrow she does not eat, she's fasting, or she's fasting for 1 day or 2 days, this glycogen is actually what is converted back to glucose. Okay, so when I talk about insulin resistance, specifically what I'm meaning is that in a woman who is having PCOS, because of the persistent levels of high glucose in her system, because of some changes taking place with the male hormones rising, and then of course changes taking place as a result of PCOS, the body fails to respond to the effect of insulin. Insulin is released, it goes to the bloodstream, but ideally instead of the insulin converting the glucose to glycogen, what happens is that the body refuses, okay? The body refuses to respond to insulin. And when the body fails to recognize insulin, then the glucose will continue rising, leading to a condition known as hyperglycemia. Hyperglycemia normally in PCOS, not every woman who has PCOS has hyperglycemia, but most of the women who have PCOS, normally they have high sugars. Another word for high sugars is what we call hyperglycemia. Hyperglycemia, high sugars in the blood. Let me translate in Luganda. Sign eyokusatu jembadde njogerako, bana, keep tapping on the screen. Yes, keep tapping on the screen so that many of our friends can join us. So Sign eyokusatu gye mbadde njogerako eya PCOS yeno gye tuyise insulin resistance. Nengamba nti insulin resistance omuntu abanga badde katugeze omukyala alidde ku muceere, alidde ku kawunga, some kaposho, alidde ku like maybe some rice. Okay, basically wabanga alidde ku mmere yonna egwa mu kika kye tuyise carbohydrates. Okay? Aliddeko ne ku ttooke, aliddeko ne ku bintu ebirala naye nga specifically omuceere, akawunga, oteekeko ne muwogo, okay? Ebintu ebyo omukyala wabanga badde abiridde very appetizing, amaze okubirya bw'ati. Ebintu ebyo byonna byalidde bigenda kubeera nga bibeera converted, okay? Mu form gye tuyise glucose, okay? Carbohydrates are converted into glucose. Glucose ono abanga abadde amaze okuforminga ekigenda okuddako agenda kutandika okweyongera mu musaayi gw'omukyala. Ndikwogera ku PCOS, okay? And ndikwogera ku sign ya PCOS gye tuyise insulin resistance egyetya. Omukyala alidde ku muceere, alidde kawunga, glucose yeeyongedde. Glucose ono buli lwe yeeyongera kuba tukimanyiddwa bulungi nti the normal erina kubeera at least within 3 up to around 7.0. Those some labs zigamba 3.5 up to 6.5. But no, what you have to take from this video is that omukyala wabanga glucose we atandise okulinnya, glucose ono n'abanga ate yeeyongedde mu musaayi gwe, obwongo bw'omukyala bugenda ku recognizinga oba bugenda kuzuula nti glucose atandise okulinnya mungi nnyo. Obwongo bujja kuweereza message, bujja kuweereza obubaka ku katundu ke tuyise ka pancreas. Akatundu kano ke tuyise pancreas kafuna obubaka okuva ku bwongo kajja kutandika okufulumya hormone gye bayise insulin. Insulin hormone eno webanga ebadde efulumye ejja kgenda mu musaayi gw'omukyala, wetuuka mu musaayi gw'omukyala ono alina PCOS. Insulin hormone eno ejja kuba eyambako okulaba nga ekwata sukaali ono glucose emuteeke mu kye tuyise glycogen. Kino kye bayise basically glucose ono aba afuuse glycogen, omukyala oyo n'aba asiibye, ojja kulaba nti olunaku lw'aba asiibye glycogen ono asobola okuddayo ate n'afuuka glucose. Kati mu mukyala alina PCOS, okay, tukyanguye. Mu mukyala alina PCOS ebiseera ebisinga hormone eno gye bayise insulin webanga eyiise mu mubiri gw'omukyala, omubiri guno gw'omukyala gugaana okubanga gukwatagana ne hormone eno, afuna kye tuyise insulin resistance. Insulin resistance kiba kitegeeza omukyala ono mubiri gwe gugaanya insulin, we gugaana insulin kiba kitegeeza glucose agenda kweyongera okulinnya. Mu mukyala alina PCOS bayinza omukebera ne bamugamba nti munaye sukaali we ali mu 10 millimoles, okay? Sukaali we ali mu 15, sukaali we ali mu. Omukyala alina PCOS abeera ku risk ey'okufuna ekirwadde ekya sukaali kye tuyise high blood sugar disease, tukiyite diabetes. Obulwadde bwa sukaali abeera ku risk ey'okufuna obulwadde bwa sukaali bwe tuyise diabetes, abeera ku risk ey'okufuna kye tuyise blood sugar disease, okay? So sinti buli mukyala alina PCOS afuna diabetes, sinti buli mukyala alina PCOS afuna irregular periods, sinti buli mukyala alina PCOS afuna hormones ez'abasajja nga nnyingi, naye ndikwogera in a general way, okay? I'm generalizing. Ndigamba nti omukyala alina PCOS, the cardinal signs omukyala zalabirako nti yandibanga alina PCOS abeera ne periods nga ziri irregular, abeera ne hormones ez'abasajja nga nnyingi, omubiri gwe gubeera n'ekye tuyise insulin resistance. Tugende mu maaso ne PCOS. Keep tapping on the screen and then keep asking your questions. Beera ngo tapping ku screen, beera ngo obuuza ebibuuzo byo byonna nja kuba nkuddamu. So PCOS omukyala amanya ati nti alina PCOS, of course waba agenze mu ddwaliro doctor we ajja mukolako check-ups ez'enjawulo omuli scan gye tuyise a pelvic ultrasound scan. Doctor we asobola okusalawo n'akola scan gye tuyise a transvaginal ultrasound scan. Yes, keep tapping on the screen. Keep tapping on the screen. Yes, beera ngo tapping ku screen, mixing oluzungu n'olulimi olwaffe wano Oluganda oluwoomu olulimu ebisoko. Yes, olulimu ebisoko. Yes. So scan bagiyita pelvic scan, a transvaginal scan. Your doctor could choose among the two. So most doctors opt for the transvaginal ultrasound scan because of the nearness to your pelvic organs. Doctor wajja kusalawo either akole pelvic ultrasound scan oba transvaginal ultrasound scan, and then of course doctors abasinga ba opting for transvaginal ultrasound scan kuba esemberera nnyo system yo. Of course pelvic nayo nungi naye etaaga omusawo nga ali so experienced naye nga nayo nungi esobola okulaga, but for PCOS diagnosis, normally the transvaginal ultrasound scan 10 eba ya kabi nnyo eba esobola okulaga exactly what is happening to the big ovarian tissue. Obugi buno buli butya, buli eno distributed on the sides oba bulina appearance eri normal. And then your doctor could also opt for other tests to really confirm whether you do have PCOS. Remember, I talked about PCOS and I said that the male hormones normally tend to rise, okay? And these hormones specifically include the DHEA, dihydroepiandrosterone, dihydroepiandrosterone. Then there's one called dihydroepiandrosterone. And then, of course, your doctor could also opt to test for testosterone, which could actually be divided into two, okay? We have the free and then we have the total. Of course, the results will be interpreted and then your doctor will be able to actually manage you. My live session is for educational purposes only. Jibeereko obaako kyoyiga and then of course kyongera okuba nga kikulaga n'oba ng'omanya jjaneyo eri etya ku lwaki okyalemedde okufuna olubuto olwa PCOS. And then of course other tests that could actually be done to really confirm that someone could be having PCOS, a woman could be having PCOS, is to actually do what we call the AMH test. Then of course your doctor could also go for the FSH test. Your doctor could also look at other tests like your prolactin hormonal levels. And then your doctor could also look at other tests. We are looking at PCOS. Your doctor could also look at other tests like LH, very fantastic hormone in PCOS. Mu hormones doctor we asobola okusalawo okukebera jukira tuli mu kusoma nengamba nti mu PCOS doctor we asobola okusalawo n'agamba nti katulabe dihydroepiandrosterone erietya DHEA erietya. Jukira mu PCOS zimanyi okulinnya nakyogeddeko mu kusooka nagambye nti mu PCOS omukyala alina PCOS zino hormones ez'abasajja zijja kulinnya. So normally onzo of course zisobola okujja results nga ziri normal naye mu PCOS zimanyi okulinnya. Normal eyinza okuba nga eri between 2 up to 4 owa PCOS amaliriza ali mu 2 oba mu 3. Then AMH anti-Mullerian hormonal test eri very fantastic mu PCOS whereby mu biseera ebisinga omukyala aba alina PCOS. AMH ene esobola okulinnya kuba tukimanyi bulungi nti n'ekisawo eky'amagi buno obugi obulina okuba nga bufuuka omwana buba tebukyasobola kufuuka mwana bubeera eno ku mabbali distributed on the peripheral part of your ovarian tissue era buba butono nnyo. Mu kisawo ekituufu ekirina okuba nga amagi gakula kiba kinene weekit nga kirina ejje eddene lye bayise the leading follicle erigenda okufuuka omwana ne bu egg reserves obuli ku mabbali. This is the normal. Mu sikaani omukyala alina PCOS ajja kubeera n'obujinga butono nnyo weebuti. Engeri ekiri nti obugi buno buba butono weebuti ate nga bungi bufulumya hormone. Jukira hormone eno gye bayise AMH eviira ddala ku bugi buno, okay? Ejje rigenda okufuuka omwana lirina ekikava kungulu, okay? Of course bakiyita the theca cell. And then waliwo obutofaali obulala obuddirira babuyita the granulosa cells. Kakati AMH hormone eviira ddala mu buno obutofaali bwe bayise bu granulosa cells. Kitegeeza nti bwe buba nga bungi nnyo more than 10 kiba kitegeeza bugenda kuyuwa hormone eno nga nnyingi nnyo. Mu mukyala alina PCOS agenda kubeera ne AMH ng'eri waggulu nnyo, high AMH. Why? Because of the many follicles. I was talking about the possible tests that could actually be done in a woman who is actually having PCOS. Remember, my live session is for educational purposes only. Yes, watch it, learn something, go discuss with your doctor. So, but then I was saying that the commonest tests that could be done in a woman who is having PCOS, the first one is the pelvic ultrasound scan, but your doctor could opt for the transvaginal. Then I talked about the hormonal tests, and I said that in PCOS, it's a known fact that the male hormones tend to rise. And I was saying that DHEA, in most cases, it's going to actually rise. There's another hormone known as the sex hormone binding globulin, SHBG. It's actually supposed to bind these hormones so that they don't rise. But in a woman with PCOS, there's going to be changes with SHBG. But let's go slow. The next hormonal test is AMH. In PCOS, because the follicles are very many, there's going to be an increase in the AMH hormonal levels. Normal is 1 up to 4, standard according to WHO. In PCOS, normally a woman could actually end up with 10. Could end up with 15, could end up with 20 or even 30 because there's high AMH. And then FSH, normally the standard is 2.5 up to around 10, okay? But in PCOS, normally what happens, because the brain is sending FSH is going to the eggs, but it's actually trying to work on your eggs. It's trying to tell your eggs to grow, but the eggs are actually not growing, because in PCOS, the eggs don't grow. They remain small. What the brain will do, it will say, what's happening? Why are the eggs not growing? The brain will pump more FSH. The more it pumps the FSH, the more the FSH rises. In PCOS, normally, the FSH levels are beyond 10. They could actually be even in 100. So in PCOS, normally they could be high FSH. But remember, your results could differ. Next, in PCOS, there's going to be changes in prolactin, but not every woman experiences prolactin changes. But because of changes that could happen with these other hormones, more so the male hormones, remember these DHEAs, there's a way they actually connect with other hormones like LH to actually produce testosterone. So prolactin, in some women it could be normal, in other women it could actually also be elevated, but not every woman who has PCOS has elevated prolactin. But then nikogera ku hormone gye bayise FSH, nengamba nti hormone eno gye bayise FSH mu bakyala abalina PCOS emanyi okulinnya. FSH hormone, follicle stimulating hormone, emanyi okulinnya. Nengamba nti oyinza okwebuuza n'ogamba nti naye musawo Gerald oyogedde ku FSH n'ogamba nti emanyi okulinnya, kijja kitya? Omukyala alina PCOS, engeri ekintu abeera n'obujinga bungi nnyo, okay? Ideally kino ekisawo ekiri nomo mubeeramu ejje eddene lye tuyise the leading follicle, lye ligenda okuba nga likula. We litafuuka mwana then nga lino liddako. Nalyo nga ligejja ne likula ne lirinda ovulation obeera nebbaawo oba tobadde nebbaawo, okay? Maybe agenze ku safari oba ezennaku mwazi misinze mubadde temumanyi nti zennaku ez'okufuniramu olubuto, lino lijja kwabika ligende, okay? Terigenda kufuuka mwana. And then eryokubiri nga olaba nti abasambi bakapiira basamba naye waliwo abeera ku bayita batya ku katebe aba awoominga nti singa oli afuna injury ng'onaddako, so egg reserves gegana amagi agabeera ku katebe nga bagalinze. Ono watafuuka mwana ono yaddako, ono watafuuka mwana ono yaddako, basically gavaayo ne gakula ne course ne gaabika ne gafuluma. So mu PCOS this is normal. Mu PCOS obugi buno bubeera butono nnyo nga buli ku mabbali kuno webuti. Are we still together? Okay. Yes, keep tapping on the screen to confirm that you're still together. Beera ngo tapping ku screen or confirming nti siriko ogera nzeeka kukyalika abaliko. So the point is this, mu mukyala alina PCOS amajige mufo kyokubanga gakula wegat, mu mukyala alina PCOS buba bujinga butono nnyo webuti nga buli distributed ku mabbali kuno. Obongo buweereza hormone gye bayise FSH. Thanks a lot. Yes, thanks a lot for tapping on the screen. I can see that I'm not talking to myself. Yes, ndabye nti siri kweyogerera nze kennyini nsinzezeeka. So mu mukyala alina PCOS obongo bugenda kuba bufulumya hormone eno gye bayise FSH. Naye jjukira FSH, follicle stimulating hormone, yerina okubanga ereeta process eno y'okubanga amagi gakula obulungi. Mu PCOS obongo buweereza hormone eno gye bayise FSH netuuka ku magi nekagamba munaye mukule mugende like mufuuke omwana. Mu mukyala alina PCOS just because obugi bwe buba butono nnyo nga buli eno ku mabbali, obugi buno bugaana okubanga buwuliriza FSH kyagamba. Okay? Yes, I'm trying to like ngezako kidiluting oberengo kitegeera obulungi mukwano gwange ndikogera ku hormones za fertility. Kati obongo bujagamba naye naweereza FSH ku luli nga ali free. Okay? Normal is 2.5 up to 10. Global according to the WHO, kitongole kitwala ebyobulamu mu nsi yonna, World Health Organization, kigamba FSH erina kubeera 2.5 up to 10. Obongo busindika FSH ne busindika FSH ku level ya free pulsatile function. Okay? FSH netuuka ku magi ne gagamba banaye mukule. Okay? Mulina okuvaamu ejji erimu erigenda okufuuka omwana. Then buno bujo butono bujja kubeera stubborn, okay? Because eggs are stubborn, okay? Because follicles are stubborn. Bujja kugetinga stubborn bujja agamba ffe tetugenda kukula, ffe twagala okusigala nga tukyali bato. Then obongo bujja agamba naye bannaye FSH buzibu ki? Naweereza FSH ku firi naye ate obugi buganya okukula ku lwaki? Obongo bujja kwongera okupampinga FSH. Bujja kwongera FSH from firi obongo budabolinga. Normally FSH is released in a doubling function, in a doubling mode of release. So FSH normally ayika in doubles, okay? Obongo bufulumya firi ne watabaawo nkyukakyuka. Obongo bugamba okay, kanyongere mugiye endala, kanyongere mugiye enene. Obongo budabolinga 6. Era watabaawo nkyukakyuka 6 plus 6 ofuna ki 12. Watabaawo nkyukakyuka 12 plus 6 ofuna ki? Ogenda okulaba nga obongo bugenda bwongera FSH, and that's why waba okoze test ya fertility mukono gwange ali ku live eno saawa zino ng'ova mu lab bava kukolako test ya FSH naye ng'ate FSH hormonal test results ziri kulaga nti oli mu 10 ate nga normal according to WHO erina kubeera 2.5 up to 10 obanga results ziraga wezi tunene kiba kitegeeza obwongo buli kufulumya hormone gye bayise FSH nnyingi nnyo naye obugi bukyagaanye buli stable ne bugamba ffe tetugenda kukula. PCOS is our main topic for today. So there are other questions coming in. I'll be able to answer. Nja kubanziramu mikwano gyaffe abalala ababuuziza ebibuuzo ebirala. So next okay, next test yeno gye tuyise prolactin nengamba nti mu mukyala alina PCOS. Abamu ku bakyala PCOS esobola okuba nga erinnya and then prolactin esobola okuba nga erinnya. I'm sorry about that. Yes, it was a slip of the tongue. Mu bakyala balina PCOS ebiseera ebisinga prolactin esobola okulinnya naye si nti buli mukyala alina PCOS nti prolactin ejja kulinnya. Mulimu abakyala balina PCOS naye nga prolactin hormone yaabwe eri normal. Okay? Naye ate singa weebuuza nti naye ku lwaki prolactin erinnya kiyinza okuba nga kiconnectinga ne changes eziri okutekinga place mu hormones zino ez'abasajja zino ze bayise zi DHEAs dihydroepiandrosterone ne hormone gye bayise testosterone. Jjukira testosterone okubanga eforminga obulungi zi hormones ze bayise progesterone, okay, ne estrogen zirina okubanga ziri within the normal ranges. Progesterone webanga etandise okunafuwa, estrogen webanga etandise okunafuwa. Jjukira PCOS ekuba zino ebbiri, ekuba progesterone nekuba estrogen. Oba negamba progesterone nti linnya nnyo muli munda n'abaana yiino akabubi omwana keyekwatako n'akula ke bayise ka endometrium ke kano. Mu PCOS ebiseera ebisinga because progesterone emanyi okulinnya mu bakyala balina PCOS munda muno mumanyi okuzimba ne muzimba nnyo wogenda mu scan. Dokita wa scan aba akoze scan ajja kugamba munnaayo wandibanga olina ekirwadde kye bayise olina condition gye bayise endometrial hyperplasia. Sagala kosanya ekigambo ekirwadde. So wa scan ayinza okugamba nti olina kye tuyise endometrial hyperplasia. Endometrial hyperplasia kiba kitegeeza nti munda muno mwazimba nnyo akabubi kalina kubeera between 8 mm up to 15 mm. That is according to your menstrual cycle day. Naye ate mu PCOS omukyala ayinza okugenda mu 30 mm. Maximum is 15 mm. Omukyala wa PCOS agenda mu 30 mm and beyond. Why? Because of high progesterone hormonal levels. And of course changes zino ezibeerawo then prolactin naye ayinza okubeera affected. Next test your doctor could test another test oba test endala doctor ojasobola okubanga akola yeno eya LH test luteinizing hormone. Luteinizing hormone, let me talk about luteinizing hormone, LH. So once again, we have the uterus, we have the mouth of the cervix, we have the womb, we have the inner lining where the baby grows from, we have the fallopian tube, fimbrial part, we have an ovarian tissue, tulina side eno wali ekisawu, okay? Mulimu of course obugi, we are talking about PCOS, obugi butono nnyo buli kumabbali eno, maybe this side, it's normal, wali ejeddene, then wali ono obugi obutono, egg reserves. LH etandika etya okubanga ekyuka mu mukyala alina PCOS. Mu mukyala alina PCOS ebiseera ebisinga kyolina okumanya kiri nti hormone eno emanyi okubanga ekyuka n'erinnya. Why? Because obwongo obw'omukyala bufulumya hormone mu kusooka gye bayise FSH n'esooka nejja negamba amagi gano nti munaye mukule. Naye jjukira nagambye nti amagi gabeera stable ne gagaana kuba matono nnyo mu size. Ekiddako kiri nti obwongo busobola okugamba nti munaye FSH olaba egaanye kanyongere FSH endala FSH n'erinnya. FSH weerinnya kyekimu ne LH naye ejja kulinnya ku lwaki naye ejja kubegamba munaye kati wabeewo ejji eddene erifuluma erina okufuuka omwana naye just because tewajja kubeerawo jji eddene erifuuka omwana era still LH ejja kwongera okubanga erinnya. Mu mukyala alina PCOS ekisobola okuddako kiri nti ebiseera ebisinga FSH emanyi okubanga erisinga nebeera very high and then LH hormone naye emanyi okubanga erinnya. Mu PCOS LH wabanga ebadde erinnye tesobola kuba nti ate ekkirira kuba tukimanyi bulungi nti LH wabanga erinnye luteinizing hormone wabanga erinnye egenda kuleetera AG line eddene okubanga livaayo ne livanga ligenda kufuuka omwana. Kati mu PCOS just because tewabaayo girino livuddeyo obwongo bwongera okubanga bukyayiwa hormone eno gye bayise LH ne obanga obadde wakava periods LH eri high wuuyo n'atera ogenda mu periods LH eri high. So mu mukyala alina PCOS results wezikulaga nti LH hormone eri high kiba kitegeeza obwongo buligezaako kulaba nga buleeta process ya ovulation naye omukyala alina PCOS ovulation eba eri affected. I hope I've answered about PCOS and then the management of PCOS. Of course okujjanjaba kwa PCOS jukira obujjanjaba bwa PCOS oba olina okubanga following guidelines eza doctor wo zaba akutaddeko. Jukira buli mukyala wanjawulo treatment ekoledde omuntu omu eyinza obutakolera mulala, so treatment has to be individualized. I was talking about PCOS and I believe by now I've answered the question about PCOS. Let me try to go through other questions. Yes. Thanks a lot for sticking around. Those who are still around, I'm really humbled. Yes, Moss Technologies, thanks a lot for joining today's live session. Mose, thanks for joining today's live session. Julius, Prosi, Kitongo, Queen, Susie, thanks for joining. Ronnie, thanks for joining. Okay, I'm looking for questions. If there are no questions, I think I'll be ending at this on PCOS. Okay, next question is coming in from. Okay, how long does it take the tubes to be blocked? Because I have recurring UTIs and yet I'm abroad. No way. Oh, sorry. So our friend is talking about persistent, let me see, to be blocked because I have recurring UTIs. Okay, then recurring UTIs. Okay, and the question is, yes, I have recurring UTIs and yet I'm abroad. Okay, then she's actually having a history of recurring UTIs. She's having recurring UTIs and she's asking, how long does it take for the tubes to be blocked? Blocked tubes. She has recurring UTIs. First of all, okay, Fina, thanks a lot for asking this question. You say that you are having recurring UTIs and you are asking how long will the tubes, how will it take for the tubes to be blocked? My humble request is that you actually change your mindset. You change the way you are actually thinking about your body, change the way you are thinking about your system. Do not think of like, now the tubes are going to be blocked, now this is going to happen, now this is going to happen. Why? Because it's actually very good for us to actually think good of ourselves, think positive. Okay, recurring UTIs, a woman with recurring UTIs doesn't necessarily actually end up with blocked fallopian tubes. Okay, if you have recurring UTIs, it doesn't mean that you are going to get blocked fallopian tubes. There's only an increased risk, but you could be having recurring UTIs and yet your tubes are actually very normal. My humble advice is that if you could actually go to your doctor and then your doctor will basically do an HSG X-ray, okay, to really confirm whether your tubes are patent or not. Okay, fallopian tubes. They will inject some liquid, contrast agent, a liquid through the private parts. Okay, inside here, this is your private part. And then that liquid is supposed to go through, seeping through the endometrium up to the fallopian tubes. If it passes through the fimbrial part, then your tubes are actually normal. If it does not pass through the tubes and then it remains here, then that particular part is having a big question mark. This particular part could be blocked. Mukwano gwafe abuuziza n'agamba nti ali wabweru w'eggwanga. Abuuziza n'agamba nti atera nnyo okufuna UTIs ezitawona, ezimutawanya buli kiseera. Ali kwebuuza aligamba naye diri agenda okufuna enseke ezizibye ne mugamba nti mukwano si kirungi kulowooleza nnyo ku side eyo kuba nti ogenda kulwala oba ogenda kola bwoti, tolowooza nnyo ku mbeera eyo kuba jjukira kyolowooza ennyo ate osobola okumaliza ng'okifunye. Yes, what you think about most of the time you can easily get. So badde nsaba kyusa endowoozayo, tolowooza nnyo ku kyabulwadde, naye webanga maybe wandyetaazeewo okubanga of undergoing a check up oba okubanga bakwekebejja, kirungi n'ogendako ewa dokita wakuli okumpi. Ogambe oli wabweru w'eggwanga, osobola ogenda ewa dokita akuli okumpi n'akola a proper assessment on you, n'akolako ne ku x-ray gye bayise HSG okonfirming enseke zo ziri zitya. Kuba oyinza okuba olowoleza mu nseke nti zaaziba naye ng'ate oli tick ng'oli normal. Okay, so teweeteekako kirwadde, teweesibako kirwadde. Next question is coming in from Okay. Samba Godfrey, thanks for joining. And Ange Dashimi, thanks for joining. Sherry Kakoza Noah, Pastor Kakoza Noah, Kutumideko, yes, Kutumideko Pastor, webale kutweyungako. Fina, very clear. Wow, thanks for appreciating Fina. Yeah, thanks for appreciating. Nango Bifiona. Okay. Yes, thanks a lot for the support from Saudi Arabia. Yes, okay. Yes, you are watching from Saudi Arabia. Greetings to all our friends in Saudi Arabia. Mikono jaffe bonna bonna abali e Saudi batumiddeko. Yes, you can actually include where you're watching from. You can tell me where you are watching this live session from, whether you are in UG, Uganda, our beloved country, or whether you are in Kenya, South Sudan, South Africa, UK, Dubai. You can actually let me know where you are watching this from and whether you prefer me answering in Luganda or in English. What about having periods 1 week before? 1 week before what? Yes, having periods 1 week before. Yeah, try to complete the question. Yes, mukwano gwaffe abuzza nti obanga ofunye periods 1 week before neŋŋamba nti kirungi naaba nga amaliriza ekibuuzo kye. Yes, try to complete the question. Yes, okay. What is PCOS? Debbie, PCOS. Let's go through again. Debbie, I suppose probably maybe you've just joined us. You are saying that what is PCOS? I've just talked about PCOS, but it doesn't hurt. Yes, it doesn't hurt for us. It doesn't hurt for us to go back to PCOS. Yeah, the notes are still here. So our friend Debbie is asking, what is PCOS? I'm going to run through very fast. I hope you'll catch up with my speed. So PCOS simply means that a woman has what we call polycystic ovarian syndrome. Polycystic ovarian syndrome. In simple terms, poly means many. Cysts, small swellings on the ovaries. Syndrome is a collection of all these symptoms. So PCOS is basically a condition. It's actually a hormonal condition. It's a hormonal condition which is actually characterized by a woman having an ovarian tissue, but with very many small swellings or small follicles. We call these cysts. Okay, this condition is normally a metabolic. Call it a hormonal condition. Okay, many women experience PCOS, and I was saying that one of the signs of PCOS is irregular periods. She's supposed to see her periods on the 11th, but she misses, and then she actually misses a month. She actually ends up missing maybe 1 month, and then maybe she sees the periods next month. And I was saying that the other sign of PCOS is hyperandrogenesis. Male hormones are very high. One of the commonest male hormones is testosterone. The other one is DHEA. There are other male hormones that could actually rise as a result of PCOS. Mukwano gwaffe abuuza n'agamba nti PCOS kyeki neŋŋamba nti kitegeeza polycystic ovarian syndrome ne signs ze zino. Neŋŋamba nti PCOS okuzuulibwa, how can PCOS be confirmed? You actually have to go to a hospital near you whereby proper tests will be done. These include a transvaginal ultrasound scan and then of course other hormonal tests according to what your doctor decides. Okay. So remember, you can always message me on WhatsApp. You can always send your questions on WhatsApp. I'll be able to reply. Yes, I've not attached my WhatsApp numbers here, but you can actually go to my profile after this session, and then you can actually get the contacts, and then you can message me. Okay, next question. Hope the questions are done. But if there are other questions, I'm right here. I can actually answer your questions. Obanga obadde olinayo ebibuuzo byonna ebikwatagana ne fertility. Yes, osobola okubuuza. Nkyaliwo wano tusobola okuba nga tuwayamuko 620. I'm about to summarize. Buli mwezi nziraba naye guno bwenziraba nga next month nziraba nga obanga okay 39 years. Okay, thanks a lot for this question. She's 39 years. Okay. And then nziraba naye guno bwenziraba nga lumu periods aziraba nga lumu. Okay, next month nziraba nga 4. Okay, oba nga 5. She's 39 years. Okay, then so she's saying that she's 39 years and her periods actually keep changing. If she sees her periods on 1st, next month she'll see them on 4th, and then the next month she'll see them on 5th. Changes are of at least 3 days, and then maybe there could actually be changes of maybe 4 days. Still, if you ask me what could be happening to a 39-year-old with periods fluctuating, okay, a difference of a range of 3 to 4 days, I would say, much as of course it's not textbook standard, like maybe seeing them on fast, but at least a difference of 4 days, a difference of 5 days, it doesn't hurt. It's actually not really a very big concern. Why? Because at 39 years old, changes are happening. Okay, at 39 years old, you're almost making 40. We know very well that when a girl makes 35 years, when a lady makes 35 years of age, there's going to be an issue. with her ovarian reserves. Okay, so at 39 years old, there's going to be an issue with her ovarian reserves. They are going to begin to decrease. Sorry, okay, the ovarian reserves are going to begin to decrease. Why? Because ideally, when you take a closer look at an egg that is supposed to be fertilized, we call this the mature egg. What is going to happen? You'll excuse me. Yes, TikTok is taking us for a break. Yes, you'll excuse me. Sigalako. Yes, wali tutwala mu break and then tujja kweyongera. Okay then, that was a small break. Yes, mwebale kubanga mukyaliko. So she said that she's 39 years old. Periods keep fluctuating between first, fourth and fifth, and I was saying that this is actually very normal. Why? Because at 39 years old, the egg reserves, the ovarian reserves are actually decreasing. Her eggs are decreasing. Why? Because at 35 years, the eggs begin to decrease markedly. When a girl has been born in this world, at birth, she's going to have 1 to 2 million eggs. Then by the age of 15, she's going to be having at least 200k to around 300k eggs. And then by the time she's 35 years, some women could actually be having 100k. This is actually according to studies that were done by the NIH, okay? The NIH, yes, National Institute of Health, a big body in the US, and they actually discovered that a woman's egg reserves reduce with age. So if at all at 39 years she's beginning to have these changes in her periods, it could actually indicate that there's something that is happening with her ovarian reserves. Normally, when she goes to a hospital and her doctor does the AMH test, her doctor does the FSH test, okay? Normally AMH could actually show that there's something happening. I don't want to guess things, but FSH could also actually be changing. Why? Because FSH is responsible for the eggs growing from the first stage to the second stage, known as the secondary stage. As a woman is approaching 45 years, FSH tends to rise. Okay, AMH tends to decrease. This can actually be correlated by her doctor. In Luganda, mukwano gwaffe agambye nti alina emyaka 39 naye ng'ate periods ze zitandise okuba nga zikyukakyuka, aziraba nga lumu, okay, then omwezi oguddako n'aziraba nga 4, omwezi oguddako n'aziraba nga 5. Ali kwebuuza ku lwaki kino kiri bwe kiti. Ne ngamba nti ku myaka 39 ebiseera ebisinga kino kiba tekyeralikiriza nnyo. Difference ey'olunaku ey'ennaku 3, difference ey'ennaku 4, as long as ziri persistent, ziri consistent, like buli mwezi oziraba naye ennaku zino 3 tezihatinga, tolina kubanga ate weekuba mu kifuba nti oba waliwo obuzibu. Why? Because omwana omuwala ng'azaliddwa ku nsi, first of all ng'akyali mu nabaana eya maama we, okay, this is a uterus, small baby inside, baby girl at 20 weeks, myezi 4, myezi 5, musawo wa scan ajagamba, baby girl gwe tulabye ebitundu by'ekyamabira ze baby girl, okay, the free lines, basawo ba scan bakitegeera kino. So scan weraga nti omwana ono muwala at 20 weeks agenda kuba alina amagi 6 ku 7, okay, 6 to 7 million eggs. Omwana ono ng'azaliddwa ku nsi agenda kuba asigaza amagi 1 to 2 million. Omwana ono ng'awezezza emyaka 15, 15 years agenda kuba asigaza amagi 2,000 ku 3,000. At 35 years agenda kuba asigaza amagi 10,000, abamu baba basigaza ejjirimu, abamu baba basigaza amagi 10, abamu baba basigaza mangi. This actually varies from woman to woman, kuba abaana abawala baba bazaalibwa buli mwana muwala abeera ne amagi ge ag'enjawulo kye tuyise her own egg reserves. So nengamba nti at 39 years old normally FSH emanyi okuba ng'etandika okulinnya. Okay, jukira tuli mu kusoma naye nga kirungi waba agenze wa doctor we ajja kola tests zino n'okwongerako tests endala nga doctor we wabasazeewo, naye FSH buli lwerinnya AMH etandika okukendeera. Ku lwaki? Obwongo oba buli kusindika FSH ku magi naye amagi agatandise okunafuwa, AMH yeeyongera okuba nga ate ekkirira. Naye jukira this is actually something not to worry about, okay, but still you can confirm this with your doctor. Yes, next question. Okay, go they balance your hormones. Okay, then yeah, actually thanks a lot for the contribution. You've said that she should go and they balance her hormones. It's actually very, very important. Avoid self-medication, okay? avoid self-medication. Do not watch a video and then go and buy a medicine, go and buy a supplement, because you could actually do self-medication and it could actually not be good. So it's always advisable that you go see your doctor, and then your doctor will do a proper assessment on you, proper clerking on you, proper treatment will be given after a proper history taking and a proper investigation. Okay, so I hope the questions are done. Next question, so what's the best family planning method? Okay, then what is the best family planning method? We've moved away from hormones, now we're going to family planning. I hope you're able to see. Yes, family planning. What is the best family planning method? Okay, yes, our friends who are on the session, you could actually drop your answers. It's a chat. I'm not supposed to be the one talking alone. Okay, you can also be answering some of these questions. Yes, I believe there are medical people on the platform, on the live session. You can actually help me. Yes, abasawo abaliko musobola okunyambako ne tubanga ate tuddamu ebibuzo bino. Naye mukwano gwaffe abuuza n'agamba nti family planning. Abuuza n'agamba, what is the best family planning? What is the best family planning method? Okay. Yes, Nengamba, I'll begin with Luganda and then I'll sum it up in English. I was saying that family planning, first of all, it has two words, okay? Family and then planning, okay? Family planning. I'm answering the question, what is the best family planning? It is divided into two. We have family and then planning. Have a family, okay? And then plan for the family. Once again, family planning means have a family and then plan for the family. There are many young girls who go to pharmacies, who go to hospitals, who go to clinics, specifically pharmacies. I want family planning. She's in high school and actually she's sexually active, and then she's like, I want family planning. My advice to all our young sisters out there, please do not engage yourself into sexual activities when you are still at school. There's time for everything, okay? That is a word of advice. There's time for everything. Be patient. Stick with your career. Stick with your books, and then that time will reach when you are actually of age. That time will reach when you actually be able to have all the fun you want. So when you are young and then you begin on family planning, actually you might not realize the effects, but maybe later on when you are married, that's when you can actually remember that, wow, I wish I delayed starting on these things, okay? Yes, so family planning means you should have a family and then plan for the family. Family planning specifically is a form of medication which is given to a couple, normally a couple that is actually trying to space their children, okay? Family planning, bwe bujjanjabi obuweebwa omukyala n'omwami kirungi mu ne mubanga mugenda babiri, bwe mubanga muli planningira family yammwe, mwagala spacing ebeerewo, and of which family planning is divided into two, okay? We have the hormonal, the one whereby hormones are administered, synthetic hormones, artificial hormones, and then we have the non-hormonal. Our friend said that, what is the best family planning? Now I'm talking about family planning. I'm digging deeper on family planning. And I was saying that for the hormonal type of family planning and the non-hormonal type of family planning, for it to actually be advised, normally it's always better that you go to a hospital as a couple. Okay, don't go alone, because you could be on family planning and yet your husband wants children, and then for you on family planning, that's why it's advisable that you go together. Okay, go together, not together. So family planning specifically, it's divided into hormonal and non-hormonal. The type of family planning a particular couple, a particular lady will get depends on many factors, including her blood pressure, including her weight, and then including other factors like for how long does she want the family planning. Her question was, what is the best family planning method? My answer is, you need to go together with your partner, and then your doctor, your registered nurse, or your clinician will be able to do a proper assessment on your blood pressure and then your weight. You could actually go for the hormonal family planning method, and yet you are already overweight, you are obese, okay? Body mass index, BMI. Okay, let's quiz BMI here. You could go for family planning and yet your BMI is above 24.5. Normal is supposed to be 18.5, okay, up to 24.5, and then you are inserted and you are going for the hormonal type of family planning. What is going to result? High blood pressure, okay, high BP. Why? Because you just went, then you started on the family planning and yet you were at risk of getting high blood pressure. So it's always advisable that you go to a hospital together with your partner, and then your practitioner, your doctor, your registered nurse, your clinician will be able to guide you, teach you about all the different family planning methods, and then the decision making in family planning, it has to be done by the couple. The musawo will not decide for you, the doctor will not decide for you. Why? Because it's you as a couple that is supposed to say, now we want to space for 2 years, we want to space for 3 months, we want to space for 1 year. I hope I've answered that question. In Luganda, mukwano gwaffe abuuziza n'agamba nti family planning ki ennungi, n'engamba nti first of all family planning kitegeeza have a family and then plan for the family. Have a family then plan for the family. N'engamba nti family planning is divided into 2. Okay, first of all, mpadde advice abaana abawala abakyasoma n'engamba nti obanga obadde okyali mu ssomero ng'okyasoma, mukwano gwange family planning gigende kompola. Oyinza obutamanya ky'osobola kufuna mu family planning paka ng'omaze okusoma, bakutiikidde, oli mufumbo, good marriage, buli kimu weekiri, then bawo n'agamba mukwano nzaaliraayoko ku bebi omu yeeka bw'ati, and then of course awo ojjukira nti emergency pills zewamiranga ng'okyasoma kumbe zaaleetadde obuzibu mu system yo. So kyandibadde kirungi obanga obadde oli mu misomo, olina muzaddewo kyali okutegekera like so omalize emisomo, okay, ebyokunyumira bijja kujja mu maaso eyo. So nengamba nti family planning specifically is divided into 2. We have the hormonal, waliwo ekika ekya family planning ekiri hormonal, then waliwo ekika ekiri non-hormonal. Hormonal mwe muli kyetuyise pills, okay, pills. Okay, pills zirimu ebika ebyenjawulo, mulimu zino eziri combined, okay, oral contraceptives mwe muli nga microgynon, okay, n'ebika ebirala bingi nnyo ebirimu hormones ebbiri, estrogen, E2 ne P4, progesterone, naye nga ziri artificial. Then nengamba nti mulimu n'empiso, that is hormonal, and then of course mulimu ne kano kebateeka ku mukono, the inner part of the arm, the inner part, okay, bakayita batya no plant, okay. So and then non-hormonal mwe muli obupiira, condoms, and then of course mwe muli ne akaweta, copper IUD. Nengamba nti family planning entuufu gy'olina okugendako kuba mukwano gwaffe abuuzizza n'agamba nti family planning kyentuufu, n'engamba nti kirungi n'osooka n'ogenda mu ddwaliro ne basooka ne bakwekebejja obulungi ne balaba blood pressure eri etya. Oyinza okugamba musawo nkuba empiso ya family planning ng'olwedde pressure zitandise okulinnya, oli mu 150 ku 100, oyagala bakukuba empiso ya family planning eri hormonal, ki ekigenda okuddako? Ogenda kuva mu 150 over 100 ofunira ddala obulwadde bwa pressure, olwedde wano oba olina pressure, okay. So wabakebedde weight yo, okay, obuzito bw'olina, and then of course ne bakebera ne pressure yo, doctor wo oba musawo asobola okuba nga akuyisa, musawo wa family planning, okay, asobola okuba nga akuyisa mu bujjanjabi oba asobola okuba nga akwadvisinga nti waliwo family planning A, B, C, D, weetaaga hormonal oba eziri non-hormonal. Then from there mujja kusalawo gwe nebbaawo mubeere nga mugenda ku family planning entuufu. Tokera ku makya n'ogamba musawo nkuba empiso, oyinza okubijjamu ate pressure, oyinza okubijjamu ate ebirwadde ebirala, abadde omutono n'ogeeja n'okoma eri. Okay, so I think that's enough about family planning. Oh, Rita love, there's no best family planning, you just take what is best for you. Yeah, very good answer, but it's best she goes to a hospital near her, and then a proper assessment will be done on her. Let me sum it up. Family planning. Sorry about the phone. I've not got my nanny. Bajita bata tripod. Yes, they want to hold the phone. I've not got it. I'm using my hand. One hand writing, one hand holding. So okay. So the point is this: family planning. What was I saying? So I was saying that family planning, specifically before it is started on, and family planning, it's actually very advisable for this particular lady to have her blood pressure checked. Okay, and then also it's advisable to have her weight also assessed or measured, and then of course other factors can also be considered before she actually begins on family planning. And I was saying that if at all she's overweight, body mass index normal is supposed to be 18.5 up to 24.5, and then her body mass index, if you have a smartphone, you can actually go on Google Play, then you download that BMI app, then you measure your body mass index. You just need to get your height and the weight. So if your body mass index is actually above 24.5, that means you are obese. already you are actually too fat. If you go on a hormonal family planning method, then there's actually a risk that you could actually end up with other complications. And then if your blood pressure, normal is supposed to be 100 up to 140 over 60 up to 90, okay? If your blood pressure, if the standard is 100 up to 140 over 60 up to 90, you never know, maybe the books have changed a bit nowadays, but this is the standard blood pressure. This is what we were taught. So if your blood pressure is around 140 over 90, you are basically not hypertensive, but you are in the early stages of maybe you are at risk of getting high blood pressure. If you went for the hormonal family planning method, there's actually a big risk that you could actually end up with issues. So how do you know this works when you never used any? Okay, yeah, the best is actually you go to a hospital and then they will do a proper assessment. Okay, you can try the others. Okay. After 14 days, nziramu. After 14 days, nziramu. After 14 days, nziramu. Okay, then. Next question is coming in from Bushira. Kutumiddeko Bushira. Yes. Webalire ddala mukwano. Kufiisa wakadde n'obeera ku live eno. Ebinyuma bingi, ebyokola bingi, wandibadde olibikola naye tuli ffenna wano ku live session. Kutumiddeko. So Bushira agambye nti after 14 days, addamu periods. After 14 days, addamu periods. 14 by 2. Kiba kitegeeza this is 8 and then here. Kiba kitegeeza cycle yo specifically. Ogambye nti after 14 days ng'oddamu. After 14 days ng'oddamu. 14 days periods. 14 days periods. Bushira, try to actually ask your question very well. Ddamu obuuza ekibuuzo kyo bulungi. Kuba ogambye nti after every 14 days oddamu periods. Mbadde nsaba like oddemu ekibuuzo kino olambulule bulungi. Okay? She said that she sees her periods after every 14 days. This could be a case of actually a very short menstrual cycle. Okay? But 14 days really. Yeah. Ask the question again. Okay? Yes. So let me jump to the next question. Okay. Consulted. Oh, Dr. Gavin. Dr. Gavin, good evening. I'm really humbled, Dr. Gavin. Thanks a lot for the kind words. I'm really so humbled. Yes, I'm your big fan. Yes, I'm your big fan too. I'm really so humbled. Yes, all our friends, check out Dr. Gavin's page. Yes, he's a fantastic doctor. Yes, and thanks a lot for the support, Dr. Gavin. I'm really humbled. Yes, I'm called Gerald Massa, by the way, and I'm a fertility coach. Gerald Massa. And I'm a fertility coach and officially certified by the American Society for Reproductive Medicine and licensed in Uganda to practice, licensed by the Uganda Nurses and Midwives Council. You can always ask me all your questions. If you have questions about fertility, yes, I can guide you. So, does PCOS cause perifembryal adhesions? Does PCOS cause prefembryal adhesions? Mark, okay? You are asking that does PCOS cause perifembryal adhesion? Let's get a new page. So mukwano gwaffe Mark abuuzizza ekibuuzo n'agamba nti okay, let's like this. Okay, I hope it's clear. So mukwano gwaffe Mark abuuza ekibuuzo n'agamba nti does PCOS cause perifembryal adhesions? PCOS and then perifembryal adhesions. Okay, mukwano gwaffe Mark abuuza ekibuuzo n'agamba nti PCOS esobola okuleeta perifembryal adhesions. PCOS esobola okuleeta perifembryal adhesions. Does PCOS cause perifembryal adhesions? This is a question coming in from our friend Mark. Yes, I'm sending my greetings to you, Mark. Thanks for the support. Yes, so let's begin. We have a fallopian tube. Okay. Then we have this part known as the fembryal part of the fallopian tube. We have that ovarian tissue. Okay, we have the suspensory ligaments holding it down here, but that's not the major issue here. We have our leading follicle here. We have the small egg reserves here. Okay, and then this part here of the fallopian tube, known as the fembryal part of the fallopian tube, is actually next to this round part, known as the ampullary part of the fallopian tube. Okay, this junction here, this roundabout, when the egg has been released during ovulation, this mature egg, after rupturing, of course with release of chemicals, pain chemicals called prostaglandins. This egg comes in and then it sits here and then it awaits the sperms to come, and then the process of fertilization takes place. The fertilized egg will travel back onto the endometrial lining, and then the pregnancy will begin. The question is, does PCOS cause perifembryal adhesions? A woman, instead of having a normal ovarian tissue, she has this PCOS ovary, okay, small eggs on the sides. Okay, this is a PCOS ovary, this is a normal ovary. So, when she has PCOS, the question is, will she get perifembryal adhesions? First of all, what are perifembryal adhesions? The fembryal part is actually this part here of the fallopian tube. Adhesion simply means that there are scars, okay? There are scars in kovu. There are scars around this part here. Will PCOS cause these scars to come? The answer is no. PCOS does not cause scars to come here. PCOS is a hormonal condition. You could call it a metabolic condition, hormonal condition. It's basically purely hormonal. Whatever is happening in your blood, okay, leads to PCOS, okay? Scars coming in here, it means that maybe previously there were some surgical procedures maybe that were done, okay? If at all this particular lady has a history of maybe surgical procedures being done on her, maybe a diagnostic laparoscopy surgery was done on her, okay, DLS, diagnostic laparoscopic surgery, maybe some other procedures were done on her, and then this part was damaged. Healing will take place. They will put her on antibiotics. Healing will take place. But after the healing has taken place, the scar, due to the previous operations, could actually remain there. The woman could end up with PCOS, but this scar was not because of PCOS. So the answer is PCOS does not cause perifembryal adhesions, okay? Yes. And of course, you can share with me in case maybe you have the evidence that PCOS causes perifembryal adhesions, but according to what I know about PCOS, it's a hormonal condition. Rarely does it cause scars. Okay, PCOS causes irregular periods, IP, irregular periods. PCOS causes your sugars to rise. PCOS causes the male hormones, okay, remember it's a hormonal condition. PCOS causes the male hormones to rise, including DHEA, including testosterone, okay, including actually other changes taking place, like even your LH hormonal levels rising. PCOS loves hormones, okay, it loves to distort hormones, but rarely does it cause scars. Scars are normally a result of previous surgery, previous operations, previous infections, previous issues, maybe previous ectopic pregnancies, okay. In Luganda, mukwano gwaffe abuze ekibuuzo nagamba nti friends is coming to 7. Okay, let me try to be fast. Mukwano gwaffe abuze ekibuuzo nagamba nti PCOS ejja kuleeta ekirwadde kye bayise perifembryal adhesions. PCOS ejja kuleeta ekintu kye bayise perifembryal adhesions. Nengamba nti nedda. PCOS tereeta perifembryal adhesions kulwaki? PCOS kyekola eyagala nnyo okukuba hormones, okay? PCOS kirwadde kya hormones. PCOS yeerumba hormones nezikyankalanya nedda wali netuula nekulinda ogezeko okufuna olubuto, okay? So PCOS specifically is a hormonal condition, era perifembryal adhesions kiba kitegeeza nti part eno ey'oluseke gye bayise the fembryal part eba erimu enkovu nga zeekwata. Enkovu zino ebiseera ebisinga ziyinza okuba nga ziva ku surgery oba okulongosebwa okwakolebwa kono omukyala sometime back, okay, maybe baali bamuzibukula enseke then ne wabeerawo kadamage ako, oba nedda olubuto lwagendako mu luseke ne lusigalamu ne bamulongoosa. Scars ezo oba enkovu ezo ziba zisigaddemu ziba zaava ku operation eyo. Enkovu zino ze bayise adhesion ziba zaava ku infection zezaaliwo edda. Yali akava mu periods n'havinga sex n'abeera ne bbaawe, omusaayi ogwo ne gukola retro flow oba ne gukola back flow ne guddayo munda muno ne genda ne gutula mu nseke. Omukyalo oyo ebiseera ebisinga omusaayi gwe gwekwatamu mu nseke gusobola okuba nga guviirako embeera eyo. So PCOS, Mark, you're asking about this? Oh, it's Mrs. K. Yeah, you're asking about PCOS and adhesions, and I was saying that no, PCOS does not actually cause perifembryal adhesions. Julian, hello, how are you doing? Aisha, Namakula, how are you doing? Thanks for the support. I'm really humbled. My UTI is not ending. Chronic UTIs, recurrent UTIs, okay? Normally, UTIs, urinary tract infections, why are they not healing? Why is it that you are getting UTIs and they are not healing? Why are UTIs not healing? Okay, let's go back to our fantastic diagram here. Humanist system, we suppose this is a lady. My UTI is not healing, KR. Yeah, you didn't put your sex. Let me suppose you are a lady. So this is the private part. We have the inner lining of your womb, And then, of course, we have the bladder, your bladder just in front here. And then we have the fallopian tube. We have the fallopian tube, and then, of course, ovary, and then ovary. And then, of course, there's a connection around here. It's a sketch, not so accurate. It's a sketch. So, and then there's that opening whereby urine comes out of your private parts, okay? So UTIs are not healing. This system here is having infections, okay? UTIs means urine tract infections, okay? Urine tract infections. This part is, it's actually not healing. She's having that chronic UTI. That chronic UTI is known as a cystitis, chronic cystitis, infection of the bladder. It's not healing. Why is it so? Why is it that her infection in the bladder is not healing? Number one, it could actually be due to what we call non-compliance. I'm going to translate it in Luganda. Ngenda chidamu Luganda ekibuuzo kino. Yes, mukwano gwange awulira Luganda togivaako live session yaffe. So it could be due to non-compliance to medications. Okay, you could be using the same medications almost every now and then. You feel sick, you go for Cipro. You feel sick, you go for Metro. You feel sick, you musawo mpaka Metro kange. Me, I love my Cipro. Don't change for me, musawo. Give me Cipro. You take Cipro until your body gets used to the Cipro. Okay, and then of course time reaches when whatever is causing the infection builds actually resistance. Okay, and then of course it will no longer respond to the Cipro. Next. The chronic UTIs could actually be due to reinfection. Okay, you're treating yourself, but your partner is not getting treatment. Okay, in English, your partner is not getting the treatment, but you are treating yourself. There's a reason as to why you could be getting persistent or chronic UTIs. It could be something to do with your immunity. When the immunity goes down, that's why nowadays probiotics are recommended in pharmacies. Probiotics, okay? And then, of course, increasing your fluid intake. And then, of course, talking about fluid intake, let me take something. Increasing your fluid intake, this actually helps to flush your kidneys, okay? And then, of course, other reasons as to why you are actually not healing, it could actually be due to the organisms themselves, the germs, the disease-causing organisms, the germs causing the UTI. Maybe they are stubborn. Okay, how can you confirm that the germs are stubborn? Your doctor will most likely do what we call a urine culture and sensitivity test. On this urine culture and sensitivity test, which is actually done when you've finished 3 weeks without taking antibiotics, okay? 3 weeks to 1 month without taking any antibiotics. Don't go for urine culture and sensitivity and yet you are on antibiotics, okay? Yes, so it's advisable you actually do not be on any medications, antibiotics, and then you go for the urine culture and sensitivity test. It can actually confirm exactly which organisms are causing this chronic UTI. You could be getting medications for maybe T. vaginalis, and yet the main culprit is Escherichia coli. You get the point? You see that, my friend? You see why the urine culture and sensitivity test is important? You could be getting medicines for T. vaginalis, and yet you are having Escherichia coli, E. coli. You could be getting medicines for E. coli, and yet you have T. vaginalis. Okay? Or you could actually be having something stubborn, such as bacterial vaginosis, combination of many of these. In Luganda, mukwano gwaffe agambye nti kulwaki UTI eri mutawanya ennyo, kulwaki tali kutereera. Okay? Kulwaki alina UTI tali kuwona. Nengamba nti ebiseera ebisinga UTI eyinza okuba nga teri kuwona. Just excuse me, just a minute. Okay. Just a minute here. Okay, then thanks for staying around. So mbadde ndigamba nti omukyala ayinza okuba nga ali kwebuuza ku lwaki UTI teri kuwona ng'ate specifically ali kujjanjaba infection gye tuyise T. vaginalis naye ng'ate alina infection ereetebwa akawuka ke bayise Escherichia coli oba E. coli oba ayinza okuba nga alina bacteriovaginosis oba ayinza okulowooza nti alina UTI naye ng'ate buzibu bulala nnyo so ekyondibadde kirungi n'aba nga agenda ne bamukolako test ey'omusulo gye bayise the urine culture and sensitivity test naye ngamba nti infection eyinza obutawona lwakuba ali ku kyetuyise oba alina kye bayise non-compliance to medication nga maybe amirako empekerero enkya n'atamira ayinza okuba nga akozesa eddagala lyerimu buli kiseera musawo mpaayo ku cipro wange musawo mpaayo ku flagelo wange okay omubiri ne gugetinga used ku mpeke eyo emu gy'akozesa of course obuwuka buli nabo bugamba okay ajja kukozesa kino then of course ne bugetinga stubborn ayinza okuba nga alina that persistent infection ng'eri kuva ku kyetuyise reinfection yejjanjabisa bawe tafunye bujjanjabi webabeera awamu ng'amusiiga oba yejjanjabisa wabagenze mu binabiro ebikyafu n'aba nga atagifuna obuto then ngamba nti infections oba UTI eyinza obutagenda ng'eri kuva ku kyetuyise poor immunity oba reduced immunity okay I hope that's enough with the UTI. Treat it but I failed to heal it. Send me a message, Alena, send me a message. Yeah, send me a message, Alena. You were asking about PCOS. How do I treat PCOS? I failed to get pregnant for 2 years. Okay. So, our friend is asking about PCOS. Remember my live sessions, my videos are in English and Luganda. So if you are okay with English, please stick on the live session. If you are okay with the Luganda version, stick on the live session. Okay, I handle English and Luganda versions. Okay, I reply in English and in Luganda. Our friend is asking that she has treated PCOS, but it's not healing for 2 years. Okay, she has failed to get pregnant. For 2 years, she has failed to get pregnant. She's asking herself, why is it that PCOS is not healing? Why is it that she's actually not getting pregnant? She has PCOS, polycystic ovarian syndrome. Why is it that for 2 years she has not got pregnant? So she's talking about how can PCOS be managed? Okay, treatment of PCOS. Of course, I'm going to like cover the overall management of PCOS, but I will not go deeper, okay, on the pharmacological part, medicine part, because according to medical law, ideally we don't talk drugs on TikTok, on social media. So she's asking that how can PCOS be managed? Number one, we need to understand that PCOS is, excuse me. So we need to understand that PCOS is a lifestyle disease. Okay? We need to understand that PCOS is a lifestyle disease. And then the other thing is that we need to understand that managing PCOS specifically involves also medications. Okay? And then also we need to understand that managing PCOS also it involves understanding your labs. Okay, you've done the tests, but you are not understanding your lab results. It's always actually very advisable that you understand your labs. Okay, that's why you need a hormone interpreter like me. I can be able to interpret your hormones and then, of course, guide you on the next steps you need to take. Of course, following your doctor's medications or recommendations. So, to manage PCOS, first of all, you could be taking medicines for PCOS, and yet your lifestyle is not in order. You could be taking medicines for PCOS, and yet the labs, okay, your lab results, your lab test results are actually showing something else. Okay, you are taking PCOS, but FSH is just increasing. Okay, FSH is still rising. You're taking medication, but your labs are showing that FSH is just rising. You're taking medications, but your AMH is still dropping, okay? I mean, AMH at first it was maybe 10. In PCOS, normally it is high. You are taking medication, but the results are showing that AMH is just increasing. From 10, it is in 20. From 20, it is going to 30. That means that the medication is not working. That means that the medication, you are not responding to the medication, okay? And that's why in most cases, your doctor will make adjustments, okay? So management of PCOS, you have to actually follow your doctor's guidelines. But basically, if you work on your lifestyle, Lifestyle, basically, I'm talking about watching what you eat or changing what you eat. You could also apply other methods like IMF, intermittent fasting, okay? You can actually begin by skipping your breakfast and then you go on adjusting like that. Look at losing weight. Look at having enough sleep, because we know very well that a woman who has PCOS, when she gets enough sleep, her body is going to release a hormone known as melatonin, okay? And we know very well that melatonin, it helps to calm down the other hormones, the AMH and the AMH and the LH that are actually surging, okay, through the ceiling, okay? So if you have enough sleep, you have PCOS. If you have PCOS, and if you begin having enough sleep, okay, you're looking at 7 to 8 hours undisturbed sleep, you sleep like a baby, there's actually a big chance that your body is going to release a hormone known as melatonin. When melatonin has been released, there's actually a good chance that these hormones are going to actually begin stabilizing, but of course together with medication. We're talking about the management of PCOS. If you look at the diet, okay, we have what we call the high glycemic foods. These include most of the foods that are actually packed and then of course sold in supermarkets, okay? I'm not against supermarkets, okay? But my advice is that if you have PCOS, you actually need to monitor what you are eating. You could look at reducing cakes. You could look at reducing things that are already prepared, okay? That are already packed, okay? And then you could actually opt for green leafy vegetables. You could actually opt for more organic foods from the garden, potatoes, nuts, eggs, okay? So if you have PCOS and you watch what you are eating, there's actually a big chance that you could actually manage this. Watch your lifestyle, follow your doctor's advice, medication, and then consistently do the labs, okay? You actually, following of course your doctor's guidelines, do the lab test to really monitor and see whether you are improving or not. PCOS can be managed. I've seen success stories of PCOS, women with PCOS, and right now as I speak, they have children, they have babies. All glory belongs to God. So in Luganda, mukwano gwaffe agambye nti PCOS agijjanjabidde emyaka 2 naye teri kuwona, ali kwebuuza akoze atya okulaba nga ajjanjaba PCOS eno. PCOS agijjanjabidde emyaka 2 teri kuwona. Nengamba nti first of all, of course, talina kujjanjabira PCOS ewaka. PCOS erina kubanga ejjanjabibwa doctor we, okay? Naye of course tugenda kuba tukyogerako wano basically for learning purposes. Nengamba nti mukujjanjaba PCOS, okay? Mukujjanjaba PCOS kirungi nnyo omukyala n'abanga amanya nti alina okubanga following kye tuyise lifestyle modification. Omukyala alina okubanga amanya nti alina okugoberera medication doctor we gy'aba amutaddeko, okay? Follow your doctor's medication. Don't stop taking medication because of maybe frustration, okay? Stick in there, you can actually get pregnant. I've seen success stories, okay? And then mukujjanjaba PCOS kirungi omukyala n'abanga ate agoberera labs kyezigamba, results zino kyezigamba. Mukusooka nga tanatandika obujjanjaba bwa PCOS, maybe FSH yali waggulu, maybe AMH yali waggulu, maybe LH yali waggulu. These are hormones, okay? Otandika ku treatment n'ogimalako ennaku 3 oba ennaku 9, kirungi nnyo of course doctor wo n'ajja kubagamba nti katuddemu ate tulabe FSH eri etya, okay? Wali waggulu, kati FSH ekyali waggulu. Oh, okay. So, results zijja kulaga FSH nga tonatandika bujjanjabi yali waggulu. After 30 days on treatment, after 60 days on treatment, ekyali waggulu oba esse. AMH yali erinye because of PCOS, wali mu 10. Otandise ku bujjanjabi. 60 days, emyezi 2 giweddeko. AMH ekyali waggulu oba nedda. LH yali waggulu, otandise ku bujjanjabi. Basically, you actually, together with your doctor, you need to consistently monitor your labs. You need to follow your doctor's advice on the medication, and then you need to work on your lifestyle. Wokola bino ebintu ebisatu, of course n'okulembeza essaala osobola ddala okubanga ofuna essanyu ery'ezzadde ng'abalala bonna bwe bali okufuna essanyu ery'ezzadde. Wow, the questions are... Okay, then because of time, it's already 7. Yeah, it's already 7. Katakwibeb, how are you? Thanks for the support. Yes. Because of time, it's already 7. We shall begin. We shall actually begin from here by the grace of God. Sundays, I'm actually not working on Sundays, but Monday, by the grace of God, we shall actually be live again, and then we shall dig deeper in issues regarding your fertility. If you have issues with fertility, okay, this is our call to action. If you have issues with fertility, PCOS, okay, you are having issues with ovulation, you are not ovulating, Let's note this down so that next week you ask questions, but basing on this. If you have issues with PCOS, you have issues with not ovulating, you have issues with irregular periods, you have issues with maybe hormonal, okay? You have issues with hormonal imbalances, and then you've done the tests, but you are not understanding the results. You can always message me on WhatsApp, okay? You can message me on WhatsApp from whichever part of the world you are watching this from, whether you are in Uganda, UK, USA, South Africa, South Sudan, Dubai. You can always message me on WhatsApp, and then, of course, we shall be able to talk more about this, okay? I'm a fertility coach. I'm called Gerald Massa, the fertility coach. Gerald Massa, the fertility hormone interpreter, certified by the American Society for Reproductive Medicine. Yes, I'm certified by the American Society for Reproductive Medicine, meaning that I can give you advice which is actually expert level, as you've seen in our in our discussions. And then, of course, I can guide you together with your doctor. I can guide you on your next steps to take on the journey of fertility. By the grace of God, we are at 52 success stories, and remember, you can actually become the next one, plus 256756. Yes. Oh, I'm not supposed to mention this on TikTok. Okay, then. So you can actually message me on these numbers, and then we shall be able to actually begin from there. You can send your messages on WhatsApp. Yes, but that will be actually, I'll be replying tomorrow because of time. Yeah, the schedule is tight. I'm supposed to handle other issues right now. But tomorrow, yes, around the lunchtime, I'll be on WhatsApp live, okay? I'll be able to reply to all your questions. Osobola okumpereza message wona wooli mu nsi. Yes, osobola okuba oweereza ebibuuzo byo oba oli mu Uganda oba toli mu Uganda. Osobola okuweereza messages zo ezikwata ku PCOS, ovulation, periods, hormone imbalances. Ogezaako okufuna olubuto naye nga biganye, weereza message wano, tuwayemuko. Bampita Gerald Massa, and I'm a fertility coach, okay? Sobola okuguidinga ku journey yo eya fertility, and then of course netulaba nga tutambulira wamu nga tukulembeza Mukama. Yes, so I think that is it for today. It's been a great week. All glory belongs back to God for the gift of life, for the gift of knowledge, for the gift of healing. And I pray for all my clients, all my friends, and I pray for myself. Yes, let's meet on Monday by the grace of God. Have a nice weekend, and bye-bye.